Hi guys, we're going to talk about sexual assault. This is chapter 29 in your book, and I'm just going to get going here. So when we think about sexual assault and sexual violence, these are broad terms that encompass unwanted sexual advances and sexual harassment to rape. Sexual assault can include combinations of females, males, adults, and children. Vulnerable populations such as disabled and older adults are often targeted. Rape is a sexual violence. So we have two different categories: attempted rape, which is the threat of rape or intention to rape that is unsuccessful. And then completed rape is any penetration, no matter how slight, of the vaginal or anus with an object or body part, or oral penetration by a sex organ of another person without the consent of the victim. Other forms of sexual assault include incest, human sex trafficking, and female genital mutilation. Sexual offenders and relationships with victims. When we think about spousal or marital rape, this is penetration of one's partner, spouse, or significant other without consent. Statutory rape is rape of a minor, assuming the minor does not have the capacity to consent to sexual activity, even if they agree or initiate it. Date rape and acquaintance rape are non-domestic relationships where the perpetrator is known to the victim. Drug-facilitated sexual assault involves drug or alcohol intoxication, resulting in the inability to give consent. The Drug-Induced Rape Prevention and Punishment Act of 1996 allows up to 20 years imprisonment and fines for anyone who intends to commit a violent crime by administering a controlled substance to an unknown individual. When we think about laws in sexual assault, we know that legal definitions, we know there are legal definitions in your state. We know that the state's reportings have requirements. All states require reporting if the victim is defined as a child by state law. Most states require reporting if the victim is a dependent adult. Identification may be withheld if that individual wishes to remain anonymous. And then state or tribal government must reimburse for sexual assault examination. And this mandate is person-centered. It gives control back to those individuals who should be the primary decision makers in personal health and legal matters. As far as epidemiology, rape victims, you can see 19.3% are women and 1.7% are men. Both male and females are more likely to be raped by males. For females, the first rape experience usually happens in about 79% of those before 25 and about 40% in those before the age of 18. Both male and female are more likely to be raped by a male. I said that. The lifetime prevalence and 12-month prevalence of intimate partner rape is estimated at about 9%. Stalking is another one that we have to be concerned about 15% of women, 6% of men. In a 12-month period of time, you can talk about 4% to 2%. And then sexual violence is usually underreported. Specialized sexual assault services. Facilities have trained sexual assault nurse examiners. These are RNs with specialized training in caring for sexual assault patients. They demonstrate competency in conducting medical and legal evaluations, and they do have that ability to be an expert witness in court. Most of these same nurses are members of the Sexual Assault Response Team, or SART. Then this is just a multidisciplinary team that cares for victims of sexual assault. When we think about our clinical picture, long-term effects can include depression, excuse me, suicide, anxiety, fear, difficulty with just daily functions, low self-esteem, sexual dysfunction, and somatic complaints. Additional effects, individuals may experience recurrent and intrusive memories, dreams, flashbacks, so some of those PTSD symptoms in response to cues that remind the individual of the assault. Sometimes they can also have dissociative symptoms, that altered sense of reality or that inability to remember, or some type of amnesia with that traumatic event. They will avoid situations, places, events, or objects that remind them of the experience. They're usually hyper alertness, easily startled. They have lots of anxiety, maybe some angry outbursts from that emotional dysregulation from the traumatic event. And for some people, they do experience depersonalization or derealization. So let's apply our nursing process here. So as we apply the nursing process, we start with assessment. For general assessment, we're talking about that initial evaluation, and it could be extremely stressful. Remember, your patient may be dealing with police reports, with social workers, with all types of people. So just keep that in mind as you go through your assessment process. As far as their level of anxiety, patients may have severe to panic levels. They may not be able to problem solve. Therapeutic techniques are imperative. As far as coping mechanisms, behavioral responses might include crying, withdrawn, smoking, use of alcohol. They may be agitated, confused, disoriented. A positive cognitive response might be, at least I'm still alive and will get to see my children again, where that negative response becomes very generalized and should be clarified. If the patient says something like, it's my fault this happened, my mother warned me about working in such a trashy place, we may need to be clarifying that information because that's a negative response. What is their availability of their support system? Remembering that verbal and nonverbal cues may help indicate the strength or weaknesses of that social network. Signs and symptoms of emotional trauma: when we're taking that history of the assault, address those immediate physical and psychological needs. Make sure you address any suicidal ideations. And then if we're thinking about our physical trauma signs and symptoms, if there's any pain or discomfort, make sure we're reporting that immediately. If there's any signs of injury, we want to inspect and palpate, find those tender spots that can really improve our evidence collection. Post-sexual assault injuries can include the face, head, neck, and extremities. We're going to collect that legal evidence, blood, oral swabs. We'll swab under the nails, the anal, genital swabs. We also want to get a really good gynecological history. When was their last menstrual cycle? Do they have any histories of STDs? And remember what your patient's been through. Try to reduce that re-victimization. Remember, they've been through a trauma, and the examination may also be trauma. The patient may feel violated again. So just be very aware as you're going through those assessment pieces. And then as far as self-assessment, we want to make sure that we're examining our feelings before encountering a patient who has been sexually assaulted. So after our thorough assessment, we can identify our priorities. Primary nursing analysis may include victim of sexual assault, rape trauma response. The diagnosis, rape trauma response, addresses longer term reactions. It's usually defined as maladaptive response that occurs to the victim after a rape associated with disorganizing lifestyle, long-term process of reorganization of that lifestyle. Some other possibilities for analysis may include disturbed personal identity. You can see those written in that middle column there. Social isolation, anxiety or fear. And then other possibilities, outcomes are going to focus on those goals for those priorities that we set in place for our patient. Overall, the expected outcome for victims of sexual assault, rape, or rape trauma responses include improved response to that traumatic experience. The plan of care must include follow-up care for post-acute phase. Improvement may be indicated prior to leaving acute care settings, which would include verbalizing details of the experience. Maybe they're expressing their feelings, understanding the common responses to assault, identifying a short-term plan to deal with the immediate situation, and connecting with a community-based rape victim advocate. When we think about implementation, we can consider counseling. This is especially important to help the survivor and significant others to separate issue of vulnerability from blame. Although that person may have made choices that made them more vulnerable, they are not to blame for the rape. They may, however, decide to avoid some of those choices in the future, walking alone late at night or excessive use of alcohol. Focus on one's behavior, which we can control, allows that survivor to believe that similar experiences can be avoided in the future. Other interventions we can consider are promotion of self-care activities, and then again, case management, which just helps that patient navigate our healthcare system. Recommended emergency nursing care protocol is going to provide that safe and private environment, access to community-based advocates, and we're going to administer that trauma-informed approach, consistent, objective, immediate medical care. So part of providing that consistent, objective, immediate medical care includes that collection of evidence by emergency nurses and physicians who know the protocols for evidence collection. We're going to do care and consultation, maybe with a sane nurse, and then medically appropriate STD prophylaxis and emergency contraceptives. And then the last step is that evaluation. Sexual assault survivors are considered to be in recovery if they're relatively free of any signs and symptoms of acute stress or PTSD. Signs of recovery can include the following. They're sleeping well with few instances of nightmares or broken sleep. They're eating as they did before the rape. They're calm, they're relaxed, they're only mildly suspicious, fearful, or restless, and they're getting some really good support from family and friends. They generally have a positive self-regard about themselves, maybe the absence or only mild instances of somatic reactions, remembering those are your the body's changing in some way. And they do start returning to pre-rape sexual functioning and interest. Some of the treatment modalities, we can talk about psychological therapies. These are usually performed by psychiatric mental health advanced practice registered nurses or other advanced professionals, and they may provide individual therapy, group therapy, and remembering that these therapies are designed for the survivors. Most will eventually be able to resume their previous lifestyle and level of functioning after supportive services and crisis counseling, but we're also providing them for our perpetrators. Psychotherapy is essential for perpetrators if we're going to change that behavior. And that concludes chapter 29 on sexual abuse. If you have any questions, you can shoot me an email or we can chat about it in class. Thanks, guys.